I'm sure there are more than 4 challenges, but the 4 that I think are most pressing is that we really do not understand completely the epidemiology of pelvic floor dysfunction, meaning that we don't understand the exposures that happen that place patients at risk for development of further problems. The second challenge is that I think that our disease states are ill-defined. Sometimes we confuse a disease state with simple changes that happen with aging, for example, and call it a problem when the majority of women actually have that finding. So it's hard to imagine that a disease state is something that everyone has. I think very limited knowledge is about the phenotype of some of these disorders. And this is well characterized by some of our treatment therapies, where a treatment therapy will be introduced. We'll think there's no way that this could possibly work based on our current understanding of the pathophysiology, yet the treatment works. What that tells me is that we are still seeing things very clumped together in terms of their etiology. Not all overactive bladder, for example, is probably the same kind of overactive bladder. There's probably different kinds. And we need to be able to have finer distinction among these different kinds so that we can tailor our treatments appropriately to patients. I think the final thing that I listed, and I think is very, very key to what we do in future work in pelvic floor dysfunction, is really defining what cure means. When I first started, cure meant that the patient was dry. And that led to many misadventures. Patients might be dry but have trouble voiding, or have terrible overactive bladder symptoms, or have recurrent urinary tract infections, all risks of any surgical intervention for stress incontinence. So clearly we needed to do more than just ask if the patient was dry. Then we said, well, let's do a little testing, try to have a little finer appreciation for the specific problem the patient had. And we still ran into problems with that because we weren't taking into account the key variable in treatment of any functional disorder, which is how much does it bother the patient. And so we're a little bit better at that now, because we do have integrated patient-reported outcomes in nearly everything that we do. But the idea that we can fix a functional problem, many of these problems are long-term, complicated problems. They wax and wane. I've tried to abandon the term fix and move towards being a treatment partner with patients, and realizing that their lives are complicated, and sometimes the interventions that we do are also going to be complicated.